Hi, my name is Stephanie Clark, and I would like to begin our historical theorist presentation on behalf of Group 2. Group 2 consists of myself, Melissa Crum, and Stephen Deweese. To begin this presentation, I would like to first discuss the biography and history of our theorist, Ida Jean Orlando Pelletier, and then I would like to discuss how and when her theory was developed. So first we'll begin with the biography and history of our theorist. Ida Jean Orlando was born August 12, 1926, and she was a first-generation Italian-American. From her early education, it's easy to see that she devoted her life studies to the profession of nursing. First, she received her nursing diploma from New York Medical College, Fifth Avenue Hospital School of Nursing in 1947. After this, she received a Bachelor's of Science degree in Public Health Nursing in 1951 from St. John's University in Brooklyn, New York. In 1954, she completed her Master's of Arts in Mental Health Consultation from Teachers College at Columbia University in New York. I thought it was interesting while I was doing research on the education of Orlando that it's noted that while she worked to complete her degree, she also worked intermittently and sometimes concurrently as a staff nurse in various areas of the hospital, as well as supervising and assistant director roles, and she also taught several courses. So it's easy to see that from her early experiences and her education that she really was devoted to the profession of nursing in many ways, especially with her education and also her career development and getting herself involved in such, so many experiences and opportunities in nursing. So just a fact about the theorist, that in 1961 she married Robert Pelletier, and I'd like to bring this up because in a lot of the research that I have done and a lot of the the works that you'll read about our theorist, it's noted that her name is Ida Jean Orlando, and that's because, a lot of her work that she had, she had a lot of significant works in her career before she was married, and, so her maiden name, Orlando, is what we'll refer to her as because a lot of the works, know her as this name. So it's easy to see from her works that Orlando devoted her life, and specifically, her life to nursing, specifically to mental health and psychiatric nursing. And this is evident by her work as a clinical nurse and researcher. Other career opportunities Orlando had was that she was an associate professor and director of a graduate program in mental health and psychiatric nursing at Yale University, and this was from 1954 and 1961. The reason that this is so significant is that it was actually during her work at Yale University from 1954 to 61 that she developed her deliberative nursing process theory, which our presentation is based upon, is this theory that she developed. I just wanted to also speak to other accomplishments in her career and say that in 1972 to 1984 she also served on the board of Harvard Community Health Plan in Boston, Massachusetts. So she had, even from her early works to her later years, many professional achievements that were very impressive. So now that we've discussed some of the background and biography on our theorist, we're going to go ahead and talk about how and when this theory was created and some of the history behind her nursing process theory. So as I had stated before, during her years spent at Yale University from 1954 to 61, Orlando actually developed her deliberative nursing process theory. The theory was based upon a study that she actually conducted while she worked at Yale University School of Nursing. To develop this theory, Orlando actually based her work on observations of experience that she was aware of between patients, students, nurses, and instructors. It is said that she used observations of roughly 2,000 interactions between nurses and patients and actually created her theory based on this information. The purpose of her study mainly was to identify and integrate factors of psychiatric mental health nursing into nursing school curriculum. So not only was she at the forefront of nursing education and bettering her own education, but she also was very driven to improve nursing education for upcoming students and actually even, in the nursing profession by means of that. To complete this study, Orlando was the project investigator of a National Institute of Mental Health grant entitled Integration of Mental Health Concepts in a Basic Nursing Curriculum. So more about the history of the theory. As the principal investigator of this grant, Orlando used this platform to attempt to define the unique role of nursing. So to explain that, Orlando's analysis of these interactions between patients, she was very dissatisfied and unhappy with getting the feeling or getting the concept that nurses' motivations were being driven by factors such as physicians' orders, hospital policies, and other areas, and were not being patient-specific and patient-oriented as main drivers for these nursing actions. She really truly believed that the patient should be the focus and at the forefront of nursing interventions, and that to best provide care for the patients, they have to have active input into the care, and it has to be individualized for each patient. This really keeps nurses focused on the patient and individualizes it among patients. So when I was doing research and I was learning of her theory and actually her beliefs, something in my own practice kind of rang a bell, and I thought it would be a good example of this in real life. So during each hospital admission, nurses are required to complete care plans on all their patients. Well, from nursing school, I think we all were very familiar with the concept of care plans and utilizing them for patients. But it really wasn't until I did some research on Orlando's theory that I kind of could see her work and how it has really influenced nursing, and I'll explain how. So for each care plan that I develop for the patients on admission, we ask them, we have different individualized care plans based upon their diagnosis and things that they are at risk for. But specifically, there are 3 questions that we ask the patients on admission. And that is, what are their priorities, and, what do they want to achieve out of this hospitalization? What are their greatest fears? And what are the preferences that could make this a better hospital experience for them? And, thinking of these questions, we ask every patient on admissions the same question, but not all patients have the same answers. That really shows that nursing really has to be individualized and specialized to each patient, because yes, we ask them all the same question, but they're not all going to have the same priorities and fears, and they're going to not all have the same preferences as for comfort and, these nurse-driven things that we can do to provide these best patient scenarios and outcomes for them. So I think that, this was a good example to me, and this stood out in my mind as a way that Orlando's theory has really, can be shown in today's nursing profession, even now. So back to the theorist and her work, it said that it was because of her belief in incorporating this nurse and patient relationship into the work of nursing that her model is accepted as one of the first to acknowledge patient participation in planning care and patient feedback. That the main point from all of her theory is that patient-specific care has to be provided by nurses to meet individual patient goals and the needs of specific patients. Orlando's work was published as a general theoretical framework for the nurse-patient relationship, and this publication was known as the Dynamic Nurse-Patient Relationship, which was published in 1961. Since the first publication of her work, it has been translated into 12 languages and is currently being reissued by the National League for Nursing. This really hits home to me because, it also shows that Orlando's work was not only so pivotal and so important and influential to, nursing care in the United States, but it also transcends into the United States and beyond, which I think is really, of great impact and importance. So in more about her work and her legacy. In 1962, so after the publication, Orlando began working at McLean Hospital in Massachusetts, and this is where she worked as a clinical nurse consultant. So it was during her work at McLean, Orlando was recognized as the first psychiatric nurse to receive a research grant from the National Institute of Mental Health. It was also that during this work at McLean, Orlando's focus was really to teach her deliberative nursing process theory and also to evaluate the outcomes of the theory. She was able to do this by teaching actually her nursing process theory in the nursing school at McLean Hospital and other local hospitals. So after this theory was taught to nursing students in these programs, her research was performed on the nurses at McLean who actually utilized her nursing process. And from these observations, Orlando published The Discipline of Teaching of the Nursing Process in 1972. So I think that that is so important and so something that is so interesting, that not only did she develop a theory that was so influential, but she also published work on how important it was, how this theory was implemented in nursing study and how the outcomes, the strengths and the weaknesses of the theory, so that it could be better taught and more, useful for other nursing programs. I thought that that was really interesting. So to further talk about Orlando's legacy, well, after completing her work at McLean Hospital, Orlando moved to Metropolitan State Hospital in Waltham, Massachusetts. After retirement, Orlando remained available to students and colleagues as a mentor. And Orlando's work continues to be revered for the benefit that it had on patient care. And her work is expanded beyond the United States and is being utilized in other countries. So I really think from all of these aspects, from her education to her career, that it really can show how influential and beneficial that Orlando's work has been on the profession of nursing. I will now allow my fellow student, Melissa Crum, to further discuss our theorist.
Hi, I'm Melissa Holmes, and I will be discussing key concepts, terms, give you a brief summary of the theory, and discuss how the theory relates to the meta-paradigm. The nursing process theory is a middle-range nursing theory. Orlando synthesized facts from observations of real-life patients to develop her theory. She gathered all this data before constructing the theory. She asserted that her theory was valid. She really believed in this theory. And then she applied it to work with patients and nurses and applied to teaching of the students. So she took this theory and traveled the world to introduce this theory and to teach this theory to everyone, because she really believed that this theory could apply to individuals alone, or even in the institution, the entire institution. Deliberative nursing process theory. What does it consist of? It consists of three main steps: the patient's behavior, the nurse reaction, and the nurse's action. So what does that mean? The breakdown of it. So you observe that your patient may be in his room, very distraught, kind of wriggling his hands, just very anxious. What would the reaction of the nurse be? Would you just walk away? No. You would actually go in, you would approach your patient, you would sit down, you would talk to them. You would say, hey, you look really upset right now. Is there something that you want to talk about? I just seen that the physician had left. Maybe they had given him a diagnosis that he really just can't deal with. So what do we do about that? It's our job to address the situation and come up with resolutions for this patient to kind of ease and comfort them in their time of distress. So that's what the nursing action is. So again, the action consists of perceptions, thoughts, and feelings, and what we do with those. The nurse focuses on the patient. That is the key concept here, focusing on the patient. We try to meet their needs efficiently. The nurse identifies perceptions about the patient's behavior. So we try to pick up cues from the patient, whether they're being, withdrawn, or, they're anxious or sad, happy, all these things, all these cues we can pick up as nurses, and we have to look at that as a signal for distress, and we have to investigate it further. We have to validate these feelings with the patient. The nurse verifies whether she has met the patient's need and determines if further action is needed. Sometimes the nurse can't do everything. We can't solve everyone's problems as much as we think that we could. Sometimes we can't. So sometimes it's better just to try to get other interdisciplinary teams involved. Maybe the social worker could give them resources in the community, or maybe a chaplain could come in and just even say a little prayer with the patient. Just a simple thing like that might help ease the patient's distress. So why was this theory developed? So Orlando developed this theory because she just really wasn't happy with the way nurses approach things. So the reason why they were doing things were more based on physician orders, institutional policies, the bottom line, and not focused on the patient's needs. And that's what really she was very focused on, was the patient himself. When was it developed? It was developed in the late 1950s to early 1960s, and like Stephanie had mentioned earlier, it was then published in 1961. So this model was the first model to acknowledge a patient's participation. So Orlando really tried to stress the importance of a patient participating in his or her own care. It included findings about the nursing process. So a general theoretical framework for the nurse-patient relationship was actually developed here, and that was really a key for her, is the nurses actually developing a rapport with their patients. The theory combined competent nursing practice and customer satisfaction. So not only are you providing excellent care and knowing that you're providing excellent care, but the patient knows that you're providing excellent care, and they're very satisfied with the results. Distress. So a couple definitions for you. Distress is the experience of a patient whose needs have not yet been met. Nursing role is to discover and meet the patient's immediate need for help. Nursing action, directly or indirectly provide for the patient's immediate need. And an outcome is a change in the behavior of a patient indicating either a relief from distress or an unmet need. A couple of key concepts for you. Orlando uses concepts of human. So it was really important for Orlando to teach that a patient is a human being, not a subject matter, not a business matter, but an actual real person. Emphasizes individuality and dynamic nature of a nurse-patient relationship. Again, so she really emphasized the importance of a nurse and a patient kind of developing that bond and that rapport to kind of help with the relationship and getting to that next level of care. Immediacy of nursing situation. Each patient's behavior assessed, determine whether it expresses a need for help. So basically, observing the patient is key, determining whether or not the patient needs help, and immediate nursing action required. So we have to act immediately. We can't put it off or walk away. We have to address the situation and try to come up with resolutions to help this patient relieve his stress. A need. Need is defined as a requirement of the patient which, if supplied, relieves or diminishes his immediate distress or improves his immediate sense of adequacy or well-being. So how is it related to the meta-paradigm? So health, Orlando believed the more help a person received, the greater their health would improve. Environment. A nurse should always observe a patient's behavior and assume that their behavior could be a sign of distress and act immediately to the situation. Nurse-patient relationship. So again, Orlando believed that a patient was not just a business matter. We have to address a patient as a human being and try to get down, to their needs and explore and come up with ways to help relieve the stress. Again, the nurse's main goal here with this theory is to relieve the patient of their helplessness. Therefore, by meeting not only the patient's physical needs, but also psychological needs, will help reduce the patient's stress and will predictably assist in the healing process. So there are many benefits to this actual theory. Many of them were, of course, improved decision-making skills, more effective resolution of staff and staff physician conflicts, and more positive nursing identity and unity. But above all, it benefited the patient themselves. So the focus here is on the patient, no one else. It's the patient. That is important here. And now I'm going to hand it over to Stephen DeWeese, who will be discussing how the theory was used in the nursing practice today. Thank you.
Hello, my name is Stephen DeWeese. I will be discussing how Ida Jean Orlando's theory affected nursing and healthcare and how the theory is used today in our nursing practice. Ida Jean Orlando is probably the second most influential theorist behind Florence Nightingale to affect nursing overall. Ida Jean Orlando stated that all patients' behavior may be a cry out for help, both verbal and nonverbal. She said it was up to the nurse to determine what needs the patients are needing currently and throughout their hospital stay. She developed what we call today as the deliberative nursing process theory. From these thoughts, the deliberative nursing process theory broke down the theory into 5 stages: assessment, diagnosis, planning, implementation, and evaluation. The assessment stage comes first, where we collect subjective and objective data about patient needs. Orlando said that during this assessment stage, the nurse collects subjective and objective data about the patient and what their needs may be. During this stage, the nurse will determine what patient's needs are. We do this every night during our work. You go in and assess your patient, find out what their needs are, whether it be blood pressure, what kind of labs we need to draw or assess. From that point, then we figure out what our next stage is going to be, which is the diagnosis stage. During the diagnosis stage, the nurse defines specific goals and outcomes based on the patient's current problem and long-term problems. The nurse will then develop nursing interventions to help the patient achieve these short-term and long-term goals. These 2 steps are formed together to individualize care plans which make goals for the patient to achieve by discharge and other time frames. So during the diagnosis stage, we find out what actual problems our patients are incurring and what we need to do to figure out the best plan of care. During this stage, we also have the planning stage, where we plan our goals and interventions. So based on our diagnosis for each individualized patient, we will then determine what we need to do to accomplish these goals, or whether we need to adjust the goals further. The next stage is implementation stage. This is where we have the care for the patient, and then we use a care plan as a timeline guide. During the implementation stage of Vitagene Orlando's deliberative nursing process, you as the nurse will start to apply the care plan to each individualized patient and try to achieve their goals and what have you previously set. This is where you can make the great strides to get our patients home quicker and more healthy. I work at St. Elizabeth on a congestive heart failure floor. So during our implementation stage, we have to focus on getting the patient healthier, but also have to watch out that we don't put the patient in fluid overload or diurese them too quick and put them in kidney failure. So you walk, during the implementation stage, we walk a fine line to get our patients healthier, but not doing so quickly that it harms the patient. During the implementation stage, this is where we take input from doctors, our own guides, and then our care plan to follow the stages and then figure out how well our patient is currently progressing. If we need to change any interventions or implement any more strategies, we could do so. Next comes the evaluation stage. We evaluate the patient based on the care plan, make any changes to the care plan if and as needed, and add any new problems to the care plan. The evaluation stage is when the nurse will determine if the patient is currently on track to complete all of the goals of their care plan. If the patient is not on track to meet their goals, the nurse can adjust the interventions to help the patient achieve the goals and keep them on track. During this stage, Orlando also stated that the nurse can add new problems or goals to the care plan as needed. If the patient has developed new issues, they can also be added to the care plan and make the interventions and any new problems as needed. So during this stage, we will evaluate how well the patient is progressing through the care plan, add any new problems, but we'll also evaluate the patient, make sure that they're not progressing in a negative way, and that if they are, we will change their care plan, also change their care, and maybe even medications to turn it around and make them go in a positive direction to going home. The goals of the deliberative nursing process theory for Vitagene Orlando is to allow the nurse to act deliberatively and not automatically. Patient gets individualized care, flexible nursing care, and we can focus on the patient rather than sticking strictly to the care plan. According to Orlando, the goal of her nursing process is to give individualized care to each patient. This care will be flexible, allowing the nurse to act deliberatively and not automatically. So basically, we want the nurse to act on an individualized basis and not just deliberately do something. You want to have a reason for what you're doing. The nurse must think of each patient as an individual, and their care is geared to their needs. The theory is universal over the entire nursing field, no matter what type of floor you work on, whether ICU, med-surg, or a telemetry unit. The theory is used every single day. When you start your shift, you go in and do your first step, which is assessing the patient. So you go in, assess, find out what needs they have, and then from that process, and then we go into the diagnosis. So you diagnose what's their problem going to be, whether or not you have a blood pressure issue that night, a lab that needs fixed, or whether or not the patient is post-surgery and then needs to get up and walk. From that, you will plan your night out. So you plan out each night, each patient's night individually. You don't focus, when you have 5 or 6 patients, you don't focus and have each patient do the same thing over. So each patient is going to have an individualized plan. Next, you would implement what your plan is for each patient. So you would start, whether walking the patient, or you individualize each plan for each patient. And then next, you would evaluate how your plan is going and how your care plan is going in the middle of the night. If your plan isn't working and they're not progressing, then you can change the goals and possibly interventions for each patient because you want them to reach those goals. You create a plan of care for each patient individually, and then we'll make those interventions to meet the goal for each patient. So overall, you just want to make sure She just wanted to make sure that each patient was an individual, had flexible nursing care, and met the goals to go home more healthy, and then to hopefully, if they go home more healthy, they do not come back as soon to the hospital. Here is our references we used for our project. Orlando's deliberative nursing process had revolutionized nursing and how we take care of our patients. She felt that the nurse-to-patient relationship was so important to the overall health of each patient and also nurse. When developing the deliberative nursing process, she made sure to focus on the patient primarily, also allowing each nurse to have the freedom and autonomy to make individualized care for each patient. Overall, we can thank Ida Jean Orlando for making nursing a more caring job and allowing us to see how well our patients progress and complete goals and care plans that we make. Overall, I think Ida Jean Orlando should be right up there, recognized and remembered, right next to Florence Nightingale and her theories. Without our nursing process, any nurse would not be able to go in and do their job effectively. We use the nursing process each night without even thinking about it. We just go in, assess our patients. We're taught since nursing school how to do this. So basically, we use this process and don't even really recognize that we do it. This concludes our group's Theorist presentation on Ida Jean Orlando from Stephanie Clark, Melissa Crum, and myself, Stephen DeWeese. We would like to thank you all for listening. Thank you.